Everybody. Yeah. Hello, good evening, everybody. It's with great pleasure that I see you all here. We have this event in person at Clinica London Academy, and we also have about up to 80 people on the webinar, which is being streamed live at the same time. There will be a chat function where you can ask questions through the chat, and at appropriate times, Michelle Ting, who is here, will pause and ask what the questions are. So you'll have plenty of opportunity, both online and in person here, to raise your hand, either virtually or physically. A few housekeeping points. Phones off. Fire exit is through the front door. Loos are downstairs, but be careful about locking them too much or you might get stuck inside. That happened earlier tonight. Coats are downstairs. You will get 2 interactive points from the GOC for attending this event. We will send you certificates automatically to all the attendees, but we're also very keen that you give us feedback through SurveyMonkey. Our next meeting will be on the 11th of February, for those of you who would like to come back. And now I have to introduce the hero of tonight, which is Michelle Ting. Michelle is an oculofacial surgeon, which is also known as Oculoplastics. She's trained for 2 years in California, in San Diego, with some of the top American oculofacial surgeons. She brings an amazing expertise back to London. Michelle is a consultant at the Royal Free Hospital, and she does her private practice here with us at Clinica London. Tonight, we're going to hear all about friend or foe, your guide to eyelid lumps and bumps. Over to you, Michelle. Thank you.
Thank you, Jane. A particular thank you to Jane, because actually about 15 years ago, I was Jane's medical student. So it is a real honor to now be at Clinica. So thank you everybody for coming. Today, we're going to discuss a very common problem that patients present with, whether that's in GP or optometry practice, and that's eyelid lumps and bumps. And you'll probably find that patients will come to you for another reason, and they'll say, oh, by the way, since I'm here, I've got this like weird thing on my face, what is that? Can you, what do I need to do about it? And there's so many different types. Sometimes it's difficult to know which ones are actually things that need to be treated and which things should be left alone. So the aim of today's talk is to discuss the common benign eyelid lumps. There's probably about 6 or 7 really common ones that if you see them often enough, it's just pattern recognition. To understand when to remove them, to recognize the red flag features that suggest that it's malignant and needs to be looked at by a specialist, and then how we treat these malignant lumps. And then I've given you a little bit of a flavor of what some of the reconstructions look like after a lump has been removed, particularly after the cancer lumps have been removed, and what patients can expect. So, everyone seen one of these? Yep. Super, super common in adults and children. Subacute or acute onset. Anyone want to shout out what it is? Yep, hordeolum, or some people, hordeolum is strictly speaking when the lash follicle itself becomes infected. This is a chalazion, which is, some people use interchangeably, which is where the meibomian gland becomes blocked. If it becomes blocked, you get a backlog of meibomian secretions behind it. And I'm sure you're probably all very familiar with the conservative treatment, which is religiously do warm compresses. And the idea of the warm compress is to get that buttery meibomian secretion to melt into an oily kind of substance, and then for it to be expressed out through the meibomian glands. One thing that patients don't realize often is that doing warm compresses just for a couple of days is not going to magically make it disappear overnight. they need to be pretty persistent with it, and it can take a number of weeks or even months to go. One tip that I like to give patients is to get a little small potato, put it in the microwave for a minute or so till it's hot, and then wrap it in a wet flannel, and then that heat from the potato keeps coming out, and you can stick that on your eye while you're watching TV or something, rather than being by the kettle or being by the hot tap and having to keep doing that, because it just makes the compliance a bit less. Sometimes when they're very inflamed, so you see some that are just kind of skin colored, but other ones that have a bit more of a red color to them. The inflamed ones we like to treat with a bit of Maxitrol ointment because it contains some steroid, and that can help the lesion go away a bit faster. And most of these, 90% of them disappear, but it can take up to a year. So if the patient is, for example, on stage or has lots of face-to-face meetings and wants it to be removed, then in the National Health, we are allowed to remove them after 6 months. Privately, obviously, a bit more flexibility, and we can do them on the same day as their appointment at Clinica. What does it involve? 10-minute procedure, bit of local anesthetic. We make the incision on the back surface of the eyelid and then scoop out the meibomian secretions. And that should make it disappear pretty quickly. Sometimes they can get more of an infection, so the whole eyelid becomes diffusely red, and so it's more of a preseptal cellulitis. So in these cases, you've got two components that you need to treat. You've got the preseptal cellulitis that you treat with augmentin, and then once that's cleared, you treat the chalazion. Okay, so a few other examples of really common benign lesions. This one, bog standard, skin tag. It's just a flesh-colored little dangly thing. Often we see it with patients who've rapidly gained weight or rapidly lost weight. Really easy to just excise if you want to. This one, this is probably the thing that I get referred most often, that people mistake for a chalazion, because it has a kind of similar round appearance. This is actually a cyst of Zeiss, which is a sebaceous gland cyst. And it's just got a bit more of a kind of whitish color. They can be smaller, they can be really, really tiny, or they can be bigger like this. These won't go away with hot compresses. So these ones, if the patient is really bothered by them, you'd need to surgically excise it. This lovely little mole here, so same thing as I've got on my chin here. It's a compound nevus. If it suddenly gets bigger, starts to change in pigmentation, or its borders become irregular, or it starts to bleed, those are kind of red flag features to look out for. Otherwise, if it's kind of just stayed the same and it's been there for years and years and years, you don't really need to worry about it. Does anyone recognize this one? Yeah, exactly. Xanthelasma, super common, can be bilateral, typically occurs at the upper medial canthus, but can also occur in the kind of tear trough region. For the GPs out here, I'm sure you know to check the serum cholesterol. And a lot of patients, you can excise them for cosmetic reasons, but there is a 40% recurrence rate. If it affects all 4 lids, then the recurrence rate goes up to about 80%. So I always tell patients that. And the other thing is that if it's largish, you may need to do some undermining to reconstruct the area. So it depends on how motivated they are and whether they're okay with having a small little mark there still. Good. Another really common referral, classic one, is a patient comes with often multiple little round fluid-filled bumps, and they transilluminate. Does anyone know what this is? Yeah, exactly, perfect. Cyst of mole, which is a sweat gland cyst. So we actually have lots of little sweat glands along the eyelid. And I have had 1 or 2 patients, it's not that common, but I have had 1 or 2 who say during the summer they get bigger because you're sweating more, and possibly that's the reason. These are really tempting to want to just lance them at the slit lamp, to just stick a needle in and get the fluid out. The problem with that is that if you don't remove the whole cyst wall, then they will come back. So to excise them, you either need to completely deroof them or just excise the whole thing in one go. Another very classic referral, which often, especially the pigmented ones, we get sent, with a question mark as to is this malignant. This has a kind of, the way I think about it is it kind of looks like a brain, has these sort of like, crenulations in it. This is a senile wart or a seborrheic keratosis. Has that classic stuck-on appearance. They often have multiple lesions similar on their back or chest. It just, the more you see of them, the more you recognize them. They just kind of look like they're stuck on. And I can see why, someone might be worried about the pigmentation and the size of this one, but it's very typical appearance once you've seen a few of them. So how do we treat them? The majority of them, the only way to really truly get rid of them is to excise them surgically, which most can be done under a local anesthetic. We can do that on site at Clinica. It takes about 15 minutes to half an hour. You only really need to remove it if it's bothering the patient, for example, if it's blocking their vision, if it's cosmetically unacceptable, if it's causing irritation. So some patients will say, every time I take my jumper off, my skin tag catches on it, and that's obviously really annoying. So we're always happy to remove lesions as long as the patient is bothered by it. And they might require a small reconstruction depending on the size and the location of the lesion, which we can do at the same time. So do we have any questions on the chat so far about? Nope, good, okay. So we've gone through really common benign lesions. And again, it's just pattern recognition, but if you're not sure, you can specifically look for signs that a lesion might be malignant. So this is already dermatology. Sometimes it's really obvious. Okay, so I've had a patient walk in, that's obviously malignant, okay, poor lady. But it's often not. The majority of cases is not always very clear. So what are the things that you might want to ask the patient about? Well, first of all, we will start with the history. So the actual lesion itself, what is it about the lesion that could suggest that it's malignant? How long has it been there? So if they say, oh God, I've had this thing since I was 5 years old and now I'm 50 and it hasn't changed at all, it is obviously not malignant. But if it's suddenly got larger, then you start to think, oh, is there something abnormal going on here? The location of the lesion is really important. So sometimes if you're not sure, but the lesion is at the medial canthus or the lower lid, that is more of a risk factor for it to be malignant, because the way the UV light hits us, our brows, hide the upper lid. So the commonest areas of the for malignancy are the medial canthus and the lower lid. So if in doubt and it's in that region, just refer them. Has it been, bleeding, weeping, crusting? Is there a change in pigmentation? All of these are potential signs of malignancy. And then there are the patient risk factors. So people with fair skin, so Fitzpatrick type 1 type of skin, a history of sun exposure. So, are they sun seekers? Do they smoke? Is there a history of radiation therapy? So that's a risk factor as well. And then a personal or family history of skin cancer. So these are all the things that I typically ask my patients. So red flags. So lots of my medical students will come to my clinic and will be able to reel off signs that they've read about in textbooks that they know are malignant, but it's that practice of actually seeing what that means and what that looks like. So telangiectasia is something that I'm sure many of you have heard of, these fine little blood vessels. And this is what they look like. So you can see here on the left side, there's that kind of through the middle, there's that little blood vessel there. And this very subtle one here, you can just see a few little fine vessels. The other thing is pearly edges. So particularly on this picture on the right, you just get this feeling that the edges have like a sheen to them. And that pearly edge is a characteristic for basal cell carcinoma. The good thing about the eyelids is that they have lots of specialized structures. So you can use those as clues for what's going on at a cellular level. So for example, lash loss. So if you start to see that the lash follicles have died and the lashes are not growing in that area, or you start to see that there's a change in the normal architecture of the eyelid from a uniform to kind of a thickened area or an area with a notch, then those are really big clues. So for these two patients, you could imagine, it's really easy to say, well, that's blepharitis, isn't it? But then actually, if you look here, there's a whole chunk of lashes missing, which, yeah, you can get some lash loss and blepharitis, but it's unusual to get this amount of thickening. And then similarly here, this could just be, a little pigmented mole or something, but then you see all the lashes in this area have gone. So that's another thing to look out for. Keratin plug is quite characteristic either for a keratoacanthoma, which sort of lies on the spectrum of squamous cell carcinoma, or a squamous cell carcinoma itself. With the keratoacanthomas, they rapidly get bigger and then they suddenly stop. But you see the central keratin plug, which is a red flag. This chap, he sat on this for 2 years. And you can see that the whole lid margin has been eaten away. So this, I think, turned out to be, I think it was an infiltrative basal cell carcinoma, but it could quite equally be a squamous cell as well. So ulceration, which is any sort of loss of epithelium. We talked just now about blepharitis, and remember that same lady, if you look at both of her eyes, actually the blepharitis, quote unquote, is only on the right eye, and the left eye looks normal. I couldn't get her to take a photo without opening her eyes really wide, so that's why she doesn't actually have lid retraction. So the classic teaching is that if there is significantly asymmetric blepharitis, one of the things that you should think about is a sebaceous cell carcinoma. So let's say somebody is over the age of 50 and they've had multiple styes or multiple chalasia or chronic blepharitis just on one side. I will always biopsy them. So, sebaceous cell is rare, but you always want to be sure. So any suspicious features, refer to oculoplastics, and they usually get seen ideally within 2 weeks. At Clinica, we would do a biopsy on the same day to confirm the diagnosis. That gets sent off to the lab, and then the treatment depends on the histology result. So for squamous cell carcinoma and basal cell carcinoma, which represent 90 to 95% of all of the malignant lesions that we see, we treat them first line with surgical excision. So surgical excision, there are 2 options. There is the traditional wide local excision, which is where you take out the lesion and then you measure about a 3 to 4 millimeter margin on either side. You cut that out and then you reconstruct it. The advantage of that is that it's all done in one sitting, but the disadvantage is that you can't tell for sure that you've got everything out until somebody's looked at it under the microscope, and then by that point, you've reconstructed it, and there may still be some left. So wide local excision, I would only use for patients with very, very well-defined lesions, and lesions that are in an area that there can be more tissue kind of sacrificed without any deficit, any functional deficit. The other option is to do a Mohs micrographic excision. So that's when the dermatologist, as you probably know, excises the malignancy, checks it in real time under the microscope, and keeps excising it in such a way that they're sure that they've got everything out. The advantage is that the tissue loss is minimal, so you're only taking out what you know to be malignant, and you're not wasting excision on healthy tissue. And the other advantage is that you, in real time, know for sure that you've got everything out. The disadvantage is obviously that there's another whole team involved, so you've got to refer to a Mohs surgeon. So not just any dermatologist, but a Mohs trained surgeon. So before we do the reconstruction, the margins should be clear. But for some patients, particularly those who are not medically fit, who wouldn't be able to tolerate the procedure under local anesthetic, maybe comorbidities, very elderly, you can either treat with radiotherapy. The issue with radiotherapy around the eyes, it can cause long-term problems, cataract, dry eye, occasionally radiation retinopathy, topical treatments as well in some cases. And often, especially with the basal cell carcinomas, close observation is perfectly reasonable. So let's say a patient is, 95, and they don't want to have any surgery. You could say, well, we'll just see you every 6 months, and that's perfectly fine. different if there's squamous cell, because then there's a risk of metastasis through lymphatics, whereas a basal cell does not metastasize. So you're just looking at the local invasion. Any questions? Yep.
First of all, are there any questions from the audience here on the first part about benign and then the second part about malignant?
It's like where you have the asymmetric blepharitis,
Yep.
or what looked like asymmetric blepharitis.
Yep.
Can you just highlight what sort of features are you looking for that makes that a sebaceous SCC?
So this one, actually, this particular one turned out not to be a sebaceous, but the classic teaching is if you get recurrent blepharitis in it unilaterally, then it can be. This one, I think, turned out to be a squamous cell, and you can see that basically there's the loss of lashes. There's like a little notch here. There's some redness and some thickening as well at the lid margin.
Can you make a comment about everting the upper eyelids?
Yes, everting the lids is a routine part of any oculoplastic exam, so it should always be done. Most of these are skin cancers, and so they grow just on the skin and don't really extend. But you should always evert the lid to look for any other, masses and bumps there.
And then there's a comment about the Mohs. There's various variations that we use, which is called slow Mohs, where on the day you get you don't involve the dermatologist, but you can involve the pathologist to do an urgent frozen section. And then, so you do that in the morning. And then if you need to take a second slither, you do that at lunchtime, and then you reconstruct after lunch. And then there's the other slow-mos is where it's paraffin. You do the excision, and then maybe 5 days later, you do the reconstruction. What are your opinions on those two routes?
So it really boils down to what resources are available to you. Some hospitals won't have a Mohs surgeon. Some hospitals won't be able to do fresh frozen sections. And then there's also the kind of logistics of, if you do something today, can you find space on your operating list in 5 days? So they're all perfectly good choices. It very much becomes a logistic question. And so I offer patients the 2 options that are available to me, but that doesn't mean that the other options are not very good options as well.
And now pointing to the people on the webinar, we've got 62 people there. Any questions from the attendees on the webinar? There was a comment about the first part. We love the hot potato and wet flannel, but what about the hot spoon?
So hot spoon could work. The only thing is I have seen one case that was presented at the ASOPRAS conference a couple of years ago, where a child had a hot spoon put on their eye and it caused a really bad burn and then a cicatricial change. So hot spoon is, as long as it's wrapped in something and you like a towel first, then that's okay.
Another question's just coming in. What about commercial products such as eye bags for, I think this is the chalasia. Oh, and there's also one about hard-boiled egg cooled down is useful. So comments on, first of all, please, on commercial products like eye bags. Where do you think they stand?
So the eye bags they're good for things like meibomian gland disease because they sort of diffusely spread the heat. But with a chalasian, you're trying to not only have heat, but you're trying to massage that lump. So you kind of want something that's going to give focal pressure on the area, which is why I kind of like the potato more than like a bag, which sort of just rests there.
I have to say, I absolutely love the hot potato wet flannel. You've taught me something tonight.
Good, good.
Right.
Do you heat up the flannel as well?
No, put a little new potato in the microwave till it's hot, get a towel, soak it under water, and then wrap that towel over the potato, and then the potato just keeps emitting the heat. And then
I assume it's warm water you soak the towel in, not cold. Yeah, okay.
water.
And how long do you leave it there for?
If they can do it for like 20 minutes, you know, get a really good massage, and you know, it takes time. Yeah, so you put the potato onto the lid, and then you press, and you want to slightly massage in the direction of that meibomian gland. So if it's the top lid, you massage down. If it's the bottom lid, you massage up.
If somebody has eyelashes missing, but there's no other sign, is that suspicious or?
Probably not. Probably not. If there's no like thickening or notch or anything, it's just a few lashes missing, then I wouldn't.
Nothing to.
I wouldn't be
Thank
too
you.
worried.
That slide where there was eyelashes missing, just wanted to have a look.
This one, yeah. Here we go. So just here. And then also on that one, you can see just here, there's no lashes from here to about here. So unless you're looking for it, it's easy to miss.
Oh, and
This was a squamous cell. Squamous cell carcinoma. Okay, great.
we have a couple more questions from the webinar. Do you have time to
Yeah,
answer them?
yeah.
Lovely. So what would be the ideal do-it-yourself blepharitis treatment if the patient cannot buy commercial products, e.g. baby shampoo?
So the problem with baby shampoo is I think it has a sort of like a detergenty effect and can cause the meibomian secretions on the surface of the eye to kind of break up, which makes the eye feel a bit more uncomfortable. Honestly, I would just get heat, like a little flannel, soak it in warm water, and then just rub at the base of the lashes. So kind of apply a bit of heat and rub very, very gently to kind of release those blepharitis collarettes. And then the heat just helps the meibomian secretions turn from a buttery consistency to more of an oil. Then omega-3 supplements as well. So cod liver oil or flaxseed oil, those are really good.
Another question, would you advise any ointment? They haven't specified whether they mean antibiotic or steroid. And I know you did say that it was inflamed, you would use Maxitrol ointment.
Yeah.
So we'll move on to the next one. Can benign lesions be excised under the NHS for cosmesis?
No.
Simply
we're-
no.
Yeah, we're not allowed to. There are so different trusts will have different criteria. We have to prove that it gets in the way of their vision. So typically it's like very, close to the visual axis, or it's touching the cornea and causing corneal surface irritation.
There is a question here about the cornea. Could the potato method induce a corneal astigmatism if done ever so regularly?
No, I wouldn't.
No,
have
I
thought
can't
so.
think. I
No.
agree with you.
Yeah,
All right, we'll move on to the third part.
great. So reconstructions. We like to do them where possible on the same day as the excision, because if you leave it a long time, then the wound starts to heal over and granulate and so on and so forth. And also the patient's obviously walking around with a patch on their eye, can't really get on with the rest of their life. So if we do Mohs, or if we do a slow Mohs with the fresh frozen sections, then they have the lesion removed in the morning, and then we reconstruct them usually on the same day in the afternoon. Or if you're having a wide local excision and reconstruction, the oculoplastic surgeon will do it all together in one sitting. Majority of these we can do under locals, particularly if they're quite small. GA or sedation is needed for the larger reconstructions or very anxious patients. Healing time, as with most lid surgery, is about 2 weeks. So bruising and swelling for a couple of weeks, 2 to 3 months to see the final anatomical result for some of them, depending on how big they are. And then up to a year for the incision line to fade. So I'll just go through some common ones that we see all the time. These are just examples. So Lesion at the lateral canthal area. The lateral canthus is really nice because there's no really important structures there. There's no tear duct, you don't get webbing. So in this kind of situation, you can just undermine a little bit around the wound, directly close it. And then within a week, okay, there's a bit of bruising, but they heal pretty quickly and pretty well. The medial canthus is a little bit more tricky than the lateral canthus. Why? Because it's a curved concave area. It's close to certain structures, so it's close to the punctum. And then the skin type is different there. So you've got the side of the nose, which is a bit thicker, and you've got the lower lid skin, which is thinner. So in the patient above, we just did a rotational flap, and that's what she looks like after about 4 weeks. On the patient below, because that lesion is, the gap is relatively large, I wanted to cover the bottom bit with thinner skin and the top bit with thicker skin. So you just do a combination of flaps. So you just want to basically avoid the webbing of the canthus here. So what do I mean by that? Sometimes patients can get like a little, I guess, I don't know how to describe it, like a web, like a little bit of skin that kind of sticks out at the inner corner. And you want to match the skin quality. The lower lid is very, very unforgiving. So it's really easy for the lower lid to be pulled down, so lid retraction or sometimes anectropion, if the reconstruction is not done properly. So the role of an oculoplastic surgeon in a lower lid defect is to avoid ectropion and also to respect the patient's natural lines. You know, everyone has natural lines on their lower lid, and those can be used. So in this patient, she had a line here and a line here, which we used. We always do horizontal reconstruction on the lower lid, never do vertical because it pulls the lid down. And this is her probably about a month or 2 after the surgery. Sometimes the defect can be full thickness. So this young lady had a basal cell carcinoma removed and the whole chunk of lid margin went. So in this situation, you need to make sure you reconstruct it so that there is a nice smooth contour and no little divot or knot, and also get the lashes in the right direction. So how do we do that? We line up the margin with 3 separate stitches to get it all completely aligned. And if it's done well and the patient's lucky, then they should do well. This lady, sorry about the slightly pixelated pictures, she had something similar, but she also lost her the top part of her canalicular system. So we put in a canalicular stent to reconstruct the tear duct and then also borrowed a little bit of tissue here. So we moved this whole lid across and then released the tendon here. You can see her about a week post-op to allow that lid to shift over. This gentleman, as you can see, he's got this nice little keratin plug, and he had this lesion probably for about 15 months. And he went to a retinal surgeon who said, oh, I think it's an abscess. And obviously it wasn't an abscess. So eventually the patient made his way to us. And by the time he had the Mohs, because it had been there for such a long time, and it was a squamous cell carcinoma, he basically lost his entire lower lid, and you can see all the fat pads coming out. So there are always options. It doesn't matter how big the defect is, there is always an option to reconstruct it. In his case, what we did is borrowed some tissue from the upper lid, like in that diagram there, swung it down, and then borrowed skin from the other side, his other lid, and put a skin graft on. And that's him at about 3 months. So he's done quite well. Remember this guy who had the ulceration for a couple of years? When I saw him in the clinic, I thought, oh God, you know, he's going to lose his whole lower lid like this guy. But it's okay, because I'll just borrow the upper lid and it'll be fine. And the other thing is that you don't know about how big the defect is until the day of the procedure. He turns up to the theatre and I'm like, oh my God, you've lost half your upper lid as well. So your initial plan goes out the window. So what do we do here? We think about reconstructing the upper lid first. So where am I going to get tissue from? There's lots of different ways of doing it. In him, what we did was we borrowed the lining of the bone from the outside of the eye socket, brought it across, that gave us the traction on the upper lid, which meant that we could borrow the tissue from underneath the upper lid to rebuild the lower lid. And then we bring the skin here up to cover that area. So the eyelids have 2 layers, and you have to reconstruct in both layers. And this is him about a month post-op. So the lid reconstructions, they can be quite forgiving if you know, if the patient's willing to go through it, and they can do well. So in summary, lid lumps and bumps are super common. They're really varied. Majority of them are benign. Common benign ones, so chalazion, cyst of mole, cyst of Zeiss, xanthelasma, seborrheic keratosis, skin tag. As long as you recognize those, you recognize 90% of the benign lesions. Malignant lesions, most commonly BCC or basal cell carcinoma, squamous cell carcinoma, and rarely sebaceous melanoma. I've not touched on melanoma because it's a kind of a whole different thing. And usually they have red flag features on the history or the exam. Referral to an oculoplastic team will enable speedy diagnosis, removal, and give them a good chance for a good functional and cosmetic outcome. Great. Any questions?
There's some questions from the people on the webinar. And one of them has said, what about melanoma? You haven't mentioned it.
I haven't mentioned melanoma. One is because it's pretty rare. And usually with those patients, you end up removing them and then removing the lesion and then having to do all sorts of other tests and referring them to a dermatologist. So the role of the oculoplastic surgeon is somewhat limited, and you tend to send them more to specialist melanoma centers.
And then there's some very positive feedback saying amazing reconstructions.
Thank you. Thank you.
Thank you very much. Here in the audience, live, are there any questions? I'll bring the microphone to you if there are.
The last slide you showed, where the gentleman had reconstruction, did the eyelashes grow
No,
in his
so
left eye?
once you've lost that lower lid with all the lash follicles, the lashes won't grow back. So if you look closely, yeah, and even in the last one, where is it? This guy, he's got no lashes there. But you tend to find that the men don't really care. Yeah.
We've got another question on the webinar.
Really?
Yeah, sure. Yeah, I was just saying it's fascinating. The results are amazing. Potato peels are used for inflammations, for cysts,
I didn't know that.
and
Yeah.
also for burns.
Oh, really? Okay. And what kind of way are they used on burns?
I think this is a chemical change that occurs and works against micro.
Oh, wow. There you go. Double benefit.
Is that raw potato peel? Amazing. There's one more on the chat. Just got to go to the laptop. In these reconstructions, what happens with meibomian glands and tear layer if the replacement tissue doesn't naturally contain them?
So you still can, so the upper and the lower lid both have meibomian glands which secrete oil. So it would be unusual to lose completely all of your upper lid and your lower lid. But you're right, if that were to happen, you would probably lose oily secretions and your eye might feel a bit more dry, but then that's more of a dry eye treatment that can be done down the line.
I agree with you. And also the oculoplastic surgeon's role is to put the eyelids back into a functional position so that they've got good blink and the tears that are there are going to be well distributed across the ocular surface. There's another comment here from Mehdi Fendry. Peroperative anatomopathologies control a part the Mohs technique.
I'm not sure that I understand.
Not quite
sorry.
sure what that means, but I think it means that yes, it's you have the Mohs and you end up with a hole that could be small or big,
Yeah.
and then it could mean that. Then you proceed with your reconstruction,
Yeah.
or it depends on what other pathologies there are. I'm not quite sure if I understand that
Yeah.
either.
I mean, that's the thing with a lot of these, if the lesion is poorly defined, like let's say, where's that guy?
Yes, if it's poorly defined, go on.
Let's say this guy, if I had done a wide local excision, I would probably have gone to maybe like here, excised that and gone there. But there's no way I would have excised all of it, because this just to me looks normal. But the advantage of the Mohs is that they can tell that, all that other upper bit is gone.
Another question here, any tips to differentiate preseptal cellulitis and chalazions, especially in young children? Because we forget often that young children get this quite badly, and they
Yeah.
also get bad preseptal cellulitis.
So with a chalazion, the thing is, if their lid is diffusely red, then by kind of definition, that is preseptal cellulitis. The question is whether there is also a chalazion that you need to treat. But usually what I would do is treat with oral augmentin first, get rid of the preseptal cellulitis, and then see if there's anything left behind. Because you don't really want to be doing a hot compress anyway on an eye which is infected, because you're just going to make the inflammation, the vasodilation worse. So I would always explain to the parents that the treatment's sort of in two components. There's the infection bit, and then there's the chalazion bit. And that kind of helps them psychologically get on top of, oh, it got better, but it hasn't got better. And why haven't you done it properly? And all this kind of stuff. If you set their expectations up to say, okay, we'll treat the cellulitis first, and then if we need to treat the chalazion, we can.
Lovely. Any other questions from our webinar people or live here?
Please read.
So the simple ones, like the lateral canthal lesion, the one at the beginning, 5 minutes, 5-10 minutes. This one about 10 minutes, 15-20 minutes. This one took me about an hour and a bit. This one was a bit longer. This was maybe an hour and a half, something like that. Yeah. I think if you do something enough, your hands just move really quickly. It's like, I don't know, it's a bit like driving. You don't really think about, I've got to change the gear and da-da-da. You just sort of do it.
Yes, if a dog runs in front of your car, you avert the car and move.
Yeah.
And in oculoplastics, you adjust to what the conditions are and what the hole is and what tissue you've got to put in. You're constantly rethinking as you go along.
Yeah, exactly. It's that constant thing. You're not thinking, I'll do this and then I'll physically do it. As you're doing it, you're thinking of the next step and the next step. And so you're probably watching a surgeon is just like, they're just continually like doing bits.
Yeah. There's amazing feedback between the hands and the eyes. You don't realize that you're actually feeling a lot. Yeah, so you can feel how thin the tissue is, what its elasticity it has. You get all those clues while you're operating, and you're constantly resetting what you're going to do next and making more decisions.
Exactly.
Probably 20 or 40 decisions get made during an operation. Going back to the common chalazion, which always interests everyone because we see it every day. Some people say that if you do too many hot compresses, you can make it worse and you bring the chalazion forward into the anterior lamella of the lid. Have you noticed that or not? Or is it just the ones we sometimes see that look worse because they've come along to us?
I haven't. So with the chalazion, it's physically in the meibomian, it's in the tarsal plate where the meibomian glands live. So there's no way physically for it to migrate. What I suppose what could happen is if there is an element of infection, then heat causes more vasodilation and it may make things look redder and more angry. So in those situations, treat the infection first. And then you can get on top of it with the hot compress.
And then lastly, if someone has a chalazion and they want to have surgery, where of course the options also to begin with are medical, how long would you wait before doing the incision and curettage from the first day they notice the chalazion to surgery? What would be
So-
the average advice there?
That really depends on where the patient's being seen. In the National Health Service, we're limited by the commissioning groups. So we're not allowed, we were not funded to do it unless the patient's had the lesion for more than 6 months and have tried conservative treatment. Privately, I always give the patient the option. I say, look, if you've had it for, let's say, a month and it's really not budged, probably I would suggest just doing it the same day. But if it's starting to get a little bit better, I say just give it another couple of weeks, do this conservative treatment, and you might find that it gets better. It's very much a case-by-case basis, and never push patients into surgery. Always give them that option and an expectation of how it might go depending on how it's responded so far.
Thank you. Going back to cleaning the eyelids and the lashes with blepharitis, and instead of using, as someone mentioned earlier, using the products like they're expensive, what about recommending something like eye makeup remover, the mild eye makeup remover, like, there's some that are not oily based, and they remove lumps of mascara off some people's eyelids.
Yeah.
Would that not be beneficial? I mention it to patients. I just
Yeah.
say, why don't you use something that is eye sensitive, and just give it a good clean with that, if they didn't want to use the other products.
Exactly. I think as long as it's gentle on the eyes,
Yeah.
then it's safe. As long as it's not stripping the tear film or anything like that. Then
Yeah,
that's absolutely
well,
fine.
it's only going to be on the exterior anyhow. I always warn very strongly not to get it into the eye.
Usually whatever we get on the eyelids eventually seeps its way under the eye.
Okay, thank you. And last question, this one here, this shot you have up here, you said this procedure took an hour and a half. Did the patient have to go under general anesthetic for that?
He did. We could have done it under sedation, but he preferred to just have a general.
Okay, thank you.
Can you take a couple more questions from the webinar people? Great. So we've got jumping from blepharitis and chalazion and back to, we're on preseptal cellulitis. Preseptal cellulitis is mainly seen in kids. You would agree with that, would you?
It's very common in kids, but we do also see it in adults.
So should we worry about adults with red swollen upper lids? Is it dangerous for adults?
So that's a good question. It is more dangerous for kids than it is for adults. And the reason is that the orbital septum, which is the sort of fibrous layer between the eyelid and the orbit, is not as well formed in children. So if I just go back to the beginning, if you have an adult with a diffusely red lid, but they have no orbital signs, so meaning they have no double vision, their visual acuity is good, their color vision is normal, then you are pretty convinced that it's a preseptal cellulitis and you can just treat with oral antibiotics. Very rare for it to spread from preseptal to orbital. In adults, just because the septum is stronger, and also it tends to be that orbital cellulitis usually comes from a sinusitis. In children though, especially children who are really small, like 1, 2, 3, if they're not responding to oral antibiotics, then I would convert them to IVs much sooner than I would an adult, because they just can become orbital cellulitis a lot quicker.
Another question, how urgent should preseptal cellulitis be referred?
Depends. So you mean from an optician?
From an optician, from an ophthalmologist, from a GP, from the community,
So
to see you as the oculoplastic surgeon?
if they can access an oral antibiotic prescription in the community, then I would start that first. And if there's not been an improvement after, I'd say, 72 hours, then they would need to be referred. But if there's no access to antibiotics, then with the same day.
Next question is back to malignancy at the medial canthus. You did mention the risks of that, but the question and comment is medial malignant lesion with possible deep extension or with deep extension. Do you indicate imaging, and how do you make a decision of whether to do that, to be conservative or not?
So if the lesion is quite clearly just sitting on the skin, then I don't recommend imaging. But when I look at the eye and the conjunctiva, if I feel that the caruncle looks a bit strange, or there's any suggestion of, for example, medial rectus restriction, then I would image, or if the lesion's really, really large or something like that. Vast majority, they don't require imaging.
And another question is about the lacrimal system at the medial canthus. A couple of your pictures, they lost their punctum canaliculi, and you said you put a tube in. Could you talk a little bit more about that?
Yeah.
Would you ever not put a tube in as well?
I think, so the way that I would do it is, if there is any canaliculus left, I will always try and salvage the tear drainage system. I like to use bicanalicular stents. So those are a stent, one long little spaghetti string. Half of it goes through the upper canaliculus, half of it through the lower, and it goes all the way into the tear duct in the nose. And it's self-retaining. So for example, I'm going to go through all the slides again, but it's a bit like a canalicular laceration. If you can see that cut end, you can put the stent into that cut end, and then the other end of the stent through the opposite punctum, and then you can suture the tissues around the stent in such a way that it reconstructs like a new canaliculus, which will be in a slightly different place to where it was originally, but it essentially does the same job. And then the stent stays in there, usually about 2 to 3 months, give or take.
Thank you very much. Well, I would like to, if there aren't any more questions, I would like to thank the webinar people for attending. We've had 65 of those, and the in-person, not inpatient, the in-person attendees here, where we've got some refreshments and drinks. I hope everyone at home is also enjoying themselves. I'd like to thank the organisers, Isabella, Louisa, Sophie and Alex. Alex doing the IT, hiding up here. And most of all, I would like to thank Michelle Ting for a fantastic lecture, very clear, beautiful slides, and absolutely beautiful surgery.
Thank you
Thank
very
you from
much.
all of
Thanks for
us.
having us.